Hi. So we're going to shift a little bit. I think a lot of the previous talks have been focused on the latter half of the reproductive life, and we're going to go right back to the start of the spectrum to the early years. And so when I started telling people that I'm doing this fellowship in Calgary in pediatric and adolescent gynecology, people are often a little stunned. They do a little double take. They don't really think about how these presentations of the reproductive system can present in children and adolescents. So we thought that would be a great talk today to talk about that. So pediatric and adolescent gynecology is a subspecialty under the umbrella of obstetrics and gynecology. And so to get there, normally somebody has done an undergrad degree of 4 years and then medical school of 3 to 4 years, depending on what program they complete. On to residency, which in Canada, obstetrics and gynecology is 5 years, and then the fellowship, which is either 1 or 2 years, with most programs in Canada and the US moving towards 2 years. And we're lucky to have one of those 3 spots here. 3 spots in Canada is here in Calgary. So this is a kind of a cross section if you kind of cut through somebody like this, and you can see the different organs there. The uterus in the middle with the cervix and the vagina. You can see the ovary. We often see pictures of the anatomy where they're kind of up hanging like this, but they're actually more kind of off to the sides of the uterus. And then showing the relationship as well with the bladder in the front and the rectum behind. So as a subspecialty service, we see patients, we receive calls from other doctors, either in the community or in the emergency room, and we give them advice to patients, for their patients on a variety of concerns. And often they may have even started or tried some of the first-line treatments, but there's some layer of added complexity in the adolescent that they feel they need to see a specialist. So we see a lot of stuff about the uterus. That's mostly periods that are either very heavy, very painful, coming on an unpredictable pattern. I know you guys just had a talk about PCOS. We also have people that are having the periods a little bit too early in their life, or the period has not come despite them expecting it to have come by now. We see things about the vulva, so it can be itchy or irritated, and there are underlying conditions as well that can contribute to that. Conditions of the ovaries, when they get twisted or have other issues with them. And we're going to talk a little bit later about fertility preservation. That's kind of under the umbrella of ovaries as well. We talk to people about contraception, as well as differences in anatomy. Maybe they have 2 uteruses, maybe they have no uteruses, and kind of everything in between. And so we see all of these presentations at our clinics. And I thought a good way to kind of go through this would be to go through a couple of patient presentations. And so none of these are real patients, but they are representative of what we see in our clinic. And so if there are similarities to something you may have heard of before, it's purely coincidental, but I think that it really speaks to the fact that the patients that we see are not alone, and the things that we see are actually still relatively common. So Iris is 4 years old, and her mother has noticed that she is often itching or scratching between her legs. She's a very busy 4-year-old. She goes to gymnastics and swimming class every week. And when her mom looks at this area of her body at bath time, she notices that it's really red and it looks kind of irritated. So they see her family doctor, who does examine that area of her body and says, I think you need to see a pediatric gynecologist. So we see her in our clinic at the Alberta Children's Hospital at a regularly scheduled appointment. We talk with Iris and her mother, and then we also look at the outside of her body. We don't do an internal exam because we can see what we need to see just from the outside. And ultimately, she's diagnosed with something called vulvovaginitis, or irritation of the vulva. So we make some recommendations for Iris about how we can help. So we recommend, under the umbrella of bathing, that she does a warm, clear water bath daily for about 10 to 15 minutes, and no soap or anything in the water. Cleaning the genitals last and in a standing position, and then air drying or pat drying that area, even with a hair dryer on cool setting, to make sure it's really dry before they put on her clothes afterwards. For toileting, we talk about front to back wiping, and then the position on the toilet. Some kids are not big enough for the traditional adult toilet, so they may need a stool or a special seat to avoid the urine kind of collecting there. They may need to lean forward with the knees apart. Sometimes we'll also have them sit backwards on the toilet because it's a little bit more narrow on that side. For sleep, we recommend like a clean cotton night dress and no underwear at night to allow that area to breathe. For clothing, cotton or other natural fibers, and to avoid close-fitting clothing as much as they can, and avoiding long periods in a bathing suit after going swimming. So with these interventions, Iris does really well, and then she doesn't need to come and see us anymore. The next patient is called Margaret, and Margaret has really bad periods as she describes them. So she's 13 years old, and her periods come every month, but they're very heavy, and she overflows her pads and tampons and gets on her clothes and her bed sheets with almost every period. She goes to see her family doctor, who prescribes tranexamic acid, as well as naproxen, which are two medicines that we use that don't have any hormones in them, but they can help the pain with the period be a little bit better and also bleed a little bit less. And her periods do get a little bit better, but not quite enough. So her doctor calls us, and we speak to that doctor through Specialist Link. We provide some advice to start an oral contraceptive pill, which contains estrogen and progesterone in it to help make her periods a little bit lighter and to have fewer of them. But still, the periods continue to be a problem, so eventually she comes to see us in our clinic. We talk through all the options again, and ultimately she decides to have management in the form of an IUD. In Calgary, we're really lucky. We have lots of resources to be able to have an IUD for a teen or adolescent patient. An IUD is a small plastic T-shaped device that's placed inside the uterus by a trained professional, and it provides a small amount of medicine to help suppress the periods. We have a few examples at our booth. If you've had a chance to come stop by, you can see what they look like. But they are about the height of an AirPod, so pretty small. And like I said, we in Calgary have the option to go ahead and place this either in our clinic with some comfort measures, with an inhaled anesthetic, something like laughing gas you might be familiar with, through the IV for some sedation, or even going to the operating room as well. So our goal is to remove the barrier of insertion for patients to be able to access this treatment, and for patients and their families to be able to choose what would be the best option for them. So ultimately, Margaret chooses to have her IUD placed in the operating room, which goes very well, and then she is able to return to school and activities without having to worry about heavy periods for 5 to 8 years. The next patient is Fernanda. We meet her in the emergency room at the South Health campus. Last night, she had a sudden onset of pain in her right lower abdomen, and it was so strong she felt nauseous and she puked. Her parents brought her to the emergency room, and the doctors ordered some blood work and an ultrasound to see if they could find out what's going on. The ultrasound shows a little cyst on her ovary and as well raises the concern for torsion. So what is torsion? Torsion is when the ovary can kind of twist around and compromise the blood supply. It can also include the uterine tube, and in rare cases, it can be even just the tube. So we talked to Fernanda and her parents about the options for management of an ovarian torsion. And we recommend a surgery to go and look at that ovary, see if it's twisted, and to restore the blood supply if it is. Because the imaging can only tell us so much. We don't always know exactly what the situation is going to be until we really look at it. We talk to them about the other things that we may do once we see it, such as the detwisting that I talked about, maybe attaching the ovary to something nearby if we look like it's going to twist again really easily, and removing a cyst if we do see that there is one there. The anesthesiologist then will also talk to them about the risks of anesthetic, and then they give informed consent. She goes to the operating room, she has a surgery where we look at the ovary, we found it's twisted 2.5 times around, so we untwist it. After that, the ovary looks very good. We remove the little cyst from the ovary and we finish our surgery. She comes to see us in clinic 6 weeks later and is doing really well with no more painful events, and the small cuts from her surgery are healing really well. Our last patient is Olu. Olu is admitted to the hospital with a severe complication from sickle cell disease, and her primary team of doctors are considering a bone marrow transplant. They ask us to see her to discuss the options for fertility preservation because of the effects of her treatment. Part of this treatment is known to be toxic to the ovaries, and so we go to see her in her room on the hospital ward at the Alberta Children's Hospital.
Thank you so much, Dr. Coutu. So I'm going to talk about something that's super exciting that we've been really working very hard at here in Calgary for the whole province for the last 18 months, and that's fertility preservation. So why are we talking about fertility preservation? I want everybody to imagine that a treatment that you need that is life-saving potentially comes with an up to 80% chance of having premature ovarian insufficiency, which in layman's terms is really premature menopause. So menopause when you're a child or a teenager, most likely before you've even had a chance to have your own biological children, if that's important. Fertility preservation is so important to survivorship after treatment that can affect the functioning of the ovaries, because second only to survival is the potential to have children in the future. This provides immense hope to patients and their families. And fertility preservation is so important for patients that may need bone marrow transplants or other treatments as part of their survivorship. So how does a consultation for this work? Well, we start by visiting the patient in the hospital and reviewing their history and what's led up to this need for a bone marrow transplant. Reduction in fertility really does depend on a lot of factors, including the type of cancer or blood disease, the kind of treatment required, and the age of the patient. For example, someone with an aggressive cancer needing high-dose chemotherapy or radiation to the pelvic organs may carry a higher risk. Additionally, the older the patient is at the time of diagnosis can also have an impact on fertility, as fertility naturally decreases after the age of 32, which means that we really do have a good opportunity to help children and teens because this is so important potentially for their future. The field of fertility preservation has grown exponentially in the last 10 years and has become readily available in Alberta. On average, we expect to see approximately 40 children per year. And Calgary has really become the hub for Alberta as well as Saskatchewan. So now what are the options for fertility preservation? The most successful option for fertility preservation for patients with ovaries is really embryo cryopreservation, which means combining an oocyte, or the eggs from the ovaries, with sperm to make an embryo. This is obviously not a realistic option for children or teenagers. The pediatric and adolescent gynecology program in Calgary offers timely referrals within 24 hours for children and adolescents to discuss options before their treatment starts. For prepubertal children, or kids that have not gone through puberty, so have not developed breasts, hair, or their first period, the only option is ovarian tissue cryopreservation, which means saving and freezing an entire ovary until a time in the future when and if the tissue would be necessary for either fertility or hormonal support. This procedure is ideal for patients that need to start high-dose treatment immediately, or in patients who are just not ready or mature enough for egg storage. And so what does this look like? This is a very small procedure where there's a camera placed in the belly button and 2 or 3 5mm or smaller incisions on the abdomen, and we remove an ovary through the belly button. This is then sent to the fertility program and frozen and stored for the future. Unfortunately, there is a cost, which is approximately $3,000 plus an additional $750 per year, which is a lot for families to consider with a short amount of time. Worldwide, they have stopped counting the number of births from ovarian tissue cryopreservation, as it is now no longer considered experimental and is shortly going to be considered the standard of care for the prepubertal patients. When a patient is then ready for fertility, sometime 10, 20, potentially even 30 years in the future, depending on their age, the tissue is placed back either inside the pelvis or, as crazy as this can sound, inside their forearm. And then the tissue is stimulated to produce eggs, which can be collected and combined with sperm through the process of IVF. Kids who have gone through puberty and had their first period have a few more options. So they can still choose to save the entire ovary, or they can choose egg freezing, which is called oocyte cryopreservation. Egg freezing involves, however, a minimum of 2 weeks preparation before treatment, which some kids may not have the luxury to have that time. It also requires patients to self-inject themselves daily with several needles or have their parents or supports give them the needles. And then they unfortunately need to have transvaginal ultrasounds, which can be a lot for those very early teens that are 12, 13, 14. And then the eggs have to be collected, again, through the vagina. This is definitely now considered the standard practice and is probably more successful than ovarian tissue, but that's just because ovarian tissue cryopreservation is still new. Again, there is quite a large cost for this, approximately $10,000, plus the cost of the drugs, as well as the yearly storage fees. So laparoscopy in children is a very safe procedure, and there's actually a very nice video through myhealth.alberta, which is 54 seconds, which goes through the procedure and is very age appropriate for children or teenagers that may need to undergo a laparoscopy, whether they have an ovarian torsion, an ovarian cyst, endometriosis, or ovarian tissue cryopreservation. So what else do we talk to kids and teenagers about when we see them for fertility preservation? The first goal is obviously seeing if families are interested before starting treatment. The other thing we have to talk to families about is potentially pausing their periods as they go through treatment, even if their treatment doesn't necessarily completely affect the ovary right at the time of the treatment. Because some of the medications that kids have as they go through cancer treatment or treatment for blood diseases cause their hemoglobins to drop very low, and so you would not want to also be having periods at the same time. We also review contraceptive needs and talk about protecting against sexually transmitted infections, as definitely in the setting of being immunocompromised, it could be very dangerous to get a sexually transmitted infection. We also like to revisit options for fertility preservation once they've finished treatment to assess their goals. And sometimes when the treatment does completely stop the functioning of the ovaries, we need to replace their hormones so that they can protect their heart, their brain, and their bones for the future. So whether we've met our patients on the phone, in our clinic, in the emergency room, or on the hospital wards, our goal is to make these first interactions for patients with a gynecologist a positive one, so that in the future, as girls grow into women, they will feel empowered to seek medical care for their women's healthcare needs. Thank you.